Hello everyone. We are going to study differential diagnosis by IHC immunohistochemistry in gynecologic pathology. So specific role of IHC in gynecologic pathology. So how you will differentiate between Paget disease and malignant melanoma with pagetoid spread. We will perform IHC. Keratin is positive in Paget disease while it is negative in malignant melanoma with pagetoid spread. Vimentin, S100 and HMB45 they are negative in Paget disease and positive in malignant melanoma with pagetoid spread. In Paget disease, K7 and K8 are best in highlighting the Paget cells because the background squamous cells they are negative for K7 and K8. Now coming to endocervical adenocarcinoma versus endometrial adenocarcinoma. The endocervical adenocarcinoma and endometrial adenocarcinoma both are positive for keratin. But vimentin is positive in endometrial adenocarcinomas while it is negative in endocervical. Carcinoembryonic antigen CEA is positive in endocervical adenocarcinomas. CD44 is also positive in endocervical adenocarcinoma, while GFAP is positive in endometrial adenocarcinoma. So endometrial carcinoma is positive for keratin, vimentin and GFAP, while endocervical for keratin, CEA and CD44. CEA is usually positive in areas of squamous differentiation in endometrial carcinoma, which may reduce the usefulness of CEA in this differential diagnosis. So CEA can also be positive in endometrial carcinoma wherever squamous differentiation is seen. Now the role of IHC in benign endocervical hyperplasia versus endocervical adenocarcinoma in situ. Benign endocervical hyperplasia is positive for keratin and carcinoma in situ also positive for keratin. CEA and CD44 they are negative in benign endocervical hyperplasia while they are positive in carcinoma in situ. If there is confusion between the endocervical adenocarcinoma in situ and microinvasive endocervical adenocarcinoma, then go for CD44, S100, CD1A and SMA, smooth muscle actin. So as there is adenocarcinoma, whether it is in situ or microinvasive, these all CD44, S100 and CD1A are positive in both cases. In addition, smooth muscle actin is negative in stroma in situ, while SMA positive in microinvasive. So Langerhans cells in stroma they are not increased in situ. So SMA is negative. While Langerhans cells in stroma they are increased in microinvasive endocervical adenocarcinoma. So smooth muscle actin will be positive. Now how to differentiate between poorly differentiated endometrial adenocarcinoma versus malignant mixed Mullerian tumor. The poorly differentiated endometrial adenocarcinomas they are positive for keratin. Vimentin may be positive or negative. Smooth muscle actin, Desmin and S100 they all are negative. Mixed Mullerian tumor, malignant mixed Mullerian tumor will be positive for keratin, also for vimentin, SMA, Desmin and S100 in heterologous elements. So all these are positive in malignant mixed Mullerian tumor. Now if there is confusion between stromal sarcoma and leiomyosarcoma, Then what IHC we have to perform? H. caldesmon, it is positive in leiomyosarcoma while negative in stromal sarcomas. SMA, MSA, they can be positive or negative, while they are positive in case of leiomyosarcoma. Desmin is negative in stromal sarcoma. Keratin may be positive or negative. Desmin positive or negative in leiomyosarcoma, and keratin will be positive in leiomyosarcoma with paranuclear inclusion like pattern. So leiomyosarcoma will be positive for H. caldesmon, SMA, MSA, desmin and keratin. Now coming to ovarian endometrioid carcinoma versus ovarian serous carcinoma. The endometrioid carcinoma, they will be positive for keratin 4-5, while serous carcinoma will be negative. Endometrioid carcinoma of the ovary, they show frequent squamous differentiation. The detection of subtle squamous differentiation favors the diagnosis of endometrioid carcinoma. That will be positive for keratin 4-5. Now, ovarian endometrioid carcinoma versus metastatic carcinoma of GIT. Ovarian endometrioid carcinoma will show positivity for CK7 and they are negative for keratin 20. While metastatic carcinoma of GIT, they show positivity for keratin 20 and will be negative of keratin 7. Keratin 7 negative and K20 positive is most characteristic of colonic adenocarcinomas. Gastric carcinomas are frequently both positive or keratin 7 negative and K20 positive. Pancreatic carcinoma are usually both positive, keratin 7 and keratin 20. Now, if there is confusion between ovarian endometrioid carcinoma with sertoliform features and sex cord stromal tumor. So, we will perform keratin 7 and inhibin. Keratin 7 will be positive in endometrioid carcinoma while it is negative in sex cord stromal tumors. In sex cord stromal tumor, inhibin will be positive and it is negative in ovarian endometrioid carcinoma with sertoliform features. So, another differential diagnosis is ovarian mucinous carcinoma and metastatic mucinous carcinoma from GIT. Ovarian mucinous carcinomas, they will be positive for keratin 7 and negative for keratin 20 or maybe positive. Metastatic mucinous carcinoma from colon, they are negative for keratin 7 and positive for keratin 20. Now, ovarian serous carcinoma versus epithelial peritoneal mesothelioma. Ovarian serous carcinoma, they will be negative for keratin 5-6, thrombomodulin and calratinin, while mesotheliomas will be positive for keratin 5-6, thrombomodulin and calratinin. Now, another differential diagnosis, ovarian clear cell carcinoma versus dysgerminoma. In both, we could find clear cell features with intracytoplasmic glycogen. So, there is confusion. We will perform keratin and EMA. Keratin and EMA both will be positive in ovarian clear cell carcinoma, while dysgerminoma will not show positivity. Now, ovarian clear cell carcinoma, in addition to be differentiated from dysgerminoma, it will also be confused with metastatic renal cell carcinoma. So, metastatic renal cell carcinoma will be positive for both keratin and vimentin, while ovarian clear cell carcinoma, it will be positive for keratin only. Now, ovarian clear cell carcinoma and yolk sac tumor. Ovarian clear cell carcinoma will be negative for alpha fetoprotein, while yolk sac tumor will be positive, and UM1 will be negative in yolk sac tumor, and it is positive in ovarian clear cell carcinoma. Ovarian transitional cell carcinoma or ovarian carcinoma with transitional cell features versus metastatic transitional cell carcinoma. So metastatic transitional cell carcinoma will be positive for keratin 20, uroplakin and thrombomodulin, while they are negative in ovarian TCC. Granulosa cell tumor versus poorly differentiated carcinoma. So granulosa cell tumor will be positive for inhibin and vimentin, while it is negative for keratin. It is positive, keratin will be positive in poorly differentiated carcinoma and inhibin will be negative. Now dysgerminoma and embryonal carcinoma and yolk sac tumor, ovarian germ cell tumors. Dysgerminoma will be positive for H-PLAP, while embryonal carcinoma and yolk sac tumor, they will show positivity for keratin, alpha fetoprotein in addition to H-PLAP. Non-trophoblastic elements and non-seminomatous tumors versus trophoblastic elements. The trophoblastic element will show positivity for keratin 7, beta HCG and H-PLAP, while non-seminomatous non-trophoblastic element will show only positivity with H-PLAP. Now, how IHC play a role in differentiating between decidua and intermediate trophoblast? Decidual cells, they are negative for keratin, inhibin, CD146 and HPL, while all they are positive in intermediate trophoblast. So intermediate trophoblast will be positive for keratin, inhibin, CD146 and HPL. Thank you.